So we are starting family medicine today. So starting from the family medicine, you have to start from here, just for your reading, like strength of recommendation, quality of life, and how much it impacted the daily life. So for the strength of recommendation, it's either strong or it's either conditional. If it's a strong recommendation, it means like a diagnostic choice or choice of choice of recommendation or all of those ones. So strong recommendation in those cases where we actually have to recommend them in without any delay, and weak recommendation is like either you can do it or you want to do it. In those cases, it's up to you. Then conditional, there are three different type of conditions. Like mostly we go with the conditional recommendation where if their age is meeting, if the patient, like how in the lung cancer screening we say the patient should be a smoker for this much year. So now this give you conditions. If they match, then we go for screening. So kind of those. Then the quality of life, it's high, moderate, or low. So for high quality, we do screening again and again, and for moderate, they do screening, sometime not much, and low, there's usually like the low socioeconomic status, the who does not go to doctors and all that. That was just for your understanding. You don't have to memorize anything from there. So it's just for your reading purpose. Now, in the side guidelines, folic acid supplements in the pregnancy, it's usually recommended 0.4 to 1. And in the patients who have neural tube defect or age more than 30, age more than 30, BMI 35, family history of neural tube defect, in those cases, we go for 4 milligram. And then it also goes all the way up to the patient who is doing the breastfeeding. So women with additional lifestyle issues, higher folic acid dose of 5 milligram can be given. Now comes from here part. I know I like it's mainly the reading, but there are certain points that you have to keep it in your head, that in which cases which test are you going to do. So for general population, if they ask you, a 30-year-old male came to you and now he wants to do testing, or like, what would the investigation or what kind of screening you will do in that cases. Like they hardly do this kind of scenarios, but if they give you, then you have an idea after 30 what kind of blood recommendations or what kind of screening you do, or what kind of blood test you are going to do, and before 30 what kind of test you are going to do, or at least what kind of recommendation as a family medicine you need to tell them. And we do see patients on the daily basis, so you don't know, maybe they can ask you question from here too. So we are doing family medicine. So I'm just on the table one. So if you can see a general population, like a patient who does not have any medical history, who does not have any condition. So in those cases, how we are going to approach that? So we are going to start with the dental hygiene, noise control, hearing protection, screening for poverty. That's very, very important. Then counseling. Wherever a patient comes, you have to talk about counseling of smoking, green vegetables like a proper diet, physical examination, sun exposure like wearing protective clothing, then drinking screening. So wherever it applied, then you are going to talk about it. It's not like every person will go with the dental hygiene. Wherever you feel like you need to talk about it, then you will talk. So like a patient is coming to you, he's like, oh, I'm having this skin problem. In those cases, are you going to talk about the sun exposure or not? Or like those cases where it's applied. Counseling to protect the STIs, nutrition counseling, and then diet with the calcium and vitamin D. Now, more than general population, we do understand how we are going to approach general population, starting from head to toe, like this, what we have to talk. But when it comes to general population, special population, now, as I told you, if they talk about 30-year-old male and a 30-year-old male, sorry, before 30-year-old. Now we are talking about pediatrics, adolescent, premenopause, perimenopause, all of those ones. So if a scenario comes from a pediatrics, in those cases, what are you going to look for as a family? So home visits for a high risk families, injury prevention. So this is what you are going to talk about overall any pediatric case. Injury to the developmental milestone. So you have to check for their milestone. Then comes the adolescent. So adolescents, one of the most important thing is talking about sexual history, contraceptives, use of condoms, and if they're in the smoking use or substance use or those ones. So in those cases, we discuss that one. Then comes the perimenopause, like more than 50. In those cases, talking about osteoporosis. That's very, very important in more than 65. Why I'm telling you? Because it could be asked, and imagine you talk about everything and you miss the most important point. And imagine in the scenario or in MCQs, they have given you a perimenopause and they have given you talking about hot flashes, talking about osteoporosis, talking about cardiovascular disease, talking about whatever it is. But you can see that they says assess for the risk of osteoporosis is more important as compared to anything else. So if you like don't know in the scenario or in the answers, oh, we do know that in perimenopause there is hot flashes, is it that the answer? No, then you have to know that which one is more important to talk about. So talking about osteoporosis is one of the most hallmark that you have to talk about in perimenopause. Then the adult more than 65, in those cases you have to check for their cognitive impairment like ADLs and IADLs. We discussed those ones. Multidisciplinary fall assessment, I keep telling you, in the older people, hearing, vision, fall assessment, these are very, very important. Then, when we are talking about the physical examination, in which physical examination you are going to check. So, in pediatrics, we already talk about eye screening, vision screening, hearing screening. So, this one, and serial height and weight, and all of those ones. So, when I come to adults, vision, hearing, whisper. So, as you can see, I was talking about this one. How do you assess the hearing assessment in more than 65? It's the whisper voice test. Although there is a audioscopy too, but usually the whisper voice test is something that you can perform in the clinic right away. So if they ask for what is your approach to do a hearing assessment in an adult, it's the whisper voice test. Obviously, if they ask for the diagnostic choice, then it's an audiometry, audioscope, all of that. Then, if there is a melanoma, then full body examination. Then again, the test for the general population. This one is important because they can ask for screening. What are the blood works that you would do? Okay, so for age and gender basis, so after 30, just for your knowledge, after 30, we do start the cholesterol screening as well. So diabetes, dyslipidemia, hypertension, cancer screening, and ultrasound for the abdominal aortic aneurysm is done in 60 to 80 years. And this is one of the most important screening, and it's not mentioned in here. It's mentioned in the in some other chapter. So you have to read at which age you have to do the abdominal aortic aneurysm, and which is the investigation to do is basically the ultrasound to do the abdominal aortic aneurysm at the age of 65 to 80. The line that you have to know on your fingertips. In pediatrics, usually we go for routine hemoglobin if you are concerned about sickle cell or thalassemia or anything like that. Then TB, you do Montu test. Then STI screening, obviously voluntarily HIV screening, gonorrhea, chlamydia, and syphilis. Syphilis, we go for the VDRL. If that came out positive, then we go for PRP. Then how you're going to do, obviously, if it's a female weight bearing, sorry, child bearing, in that cases, we go for folic acid. Then the pharmacological varicella vaccine for the children's about 1 to 12. Then rubella vaccine, tetanus vaccine, pertussis vaccine, and then herpes zoster in more than 50. In pediatrics, routine immunization, influenza risk, HPV, TB, and immunocompromised. This table is very, very important. Don't ignore it. I know, I understand. It's a very easy and straightforward table. So please do give it a read and see which age, what test, and what blood test or what investigations you are going to do, especially in the special population. Then we are talking about the breast cancer screening. In this one, what you need to do is which age, what is the test, and how often you are going to do, when you are going to stop. Simple. So which age? 50 to 74 you are going to start. So basically starting from 50. If there is anyone who is more prone or having family history, in those cases we can start early as well. Or if someone has a lipoma, fibroadenoma, or any lesion or any breast mass, anything like that, in those cases we can start early. Okay, so for your understanding, I'm telling you as a condition, if they give you a scenario where they tell you that a female is having a fibroadenoma or a lipoma or a mass in her breast, and she's 30 years old or 25 years old, in that case we do start mammogram, and then from there on we can follow with ultrasound, or we can start with ultrasound and then go for mammogram. Then recommend screening with mammogram, and how often do you going to do is 2 to 3 years, and then you are going to finish it up into 74 years. Okay, so undergo screening is conditional on the relative value that the woman, places on the possible benefits and harms from the screening. So if someone does not want to go for that, it's okay. You can always counsel, but at the end of the day, it's their choice. So in that cases, you need to see. Uh, Then this says for women 40 to 49. So I was just telling you that it can be started at 50, but in the patient who has more risk, like lesions, fibroadenoma, whatever it is, in those cases, we can start early as we can. So just for your thing, there is no self-examination that is recommended one. Okay. So female who ask for self-examination, or if they ask you in the scenario, is the self-examination recommended? It's a no. Then comes the lung cancer. Lung cancer screening is a conditional screening. Okay. It's not for everyone. It's for the people who have smoking history, for your understanding. And now it can be given to you where you have to calculate the pack. Okay. So if this says that a female is doing a smoking for like she's smoking from last 10 years, oh sorry, she quit smoking last 10 years ago, 50 years, she is 60 years and she quit smoking 10 years ago. She was smoking uh, one pack per day. Okay. Or she was smoking 12 sticks per day, something like that. Okay. So in that case, is you understand how many sticks are in one pack. I think approximately 30 sticks are there, or around that. So if you make an understanding of that one, so if we go by 12 sticks, if he's taking, so approximately he can finish one pack up in 2 to 3 days. So if you go by that, and there are 365 days, so if he's taking that much, so you have to calculate it, approximately it's more than 30 pack. So if roughly it makes sense to you when you are calculating it. So someone says okay, 20 cigarettes in one pack, so around 20 cigarettes. So if someone is giving you a 12 sticks per day or 10 sticks per day, in that case you have to multiply and see if it's more than 30 packs. With your understanding, if they gave you more sticks, for me, I feel like if they give you more than 5 sticks per day, or if they give you even 3 sticks per day, even if they're taking 1 stick per day, they're still taking 365 sticks per year. So it does make more than 30 pack per day, per year. Okay. So with your understanding, it is basically they're talking about there are more than 30-year pack smoking. And then that quit part is very, very important, that he hasn't quit until, like I said, 10 years. So he was smoking until 10 years. In that case, it is applied to that one. So 55 to 74 within more than 30 pack year smoking history, or who currently smoke, or even if they say quit 15 years or less than 15 years. This word is very, very important. Obviously, someone who is doing smoking right now, we do go for screening. But if someone is quit smoking 7 years, 10 years, 12 years, even 14 years, we do screening. But more than 15, we can see how much potential risk of he is having a lung cancer, like he is having shortness of breath, or having a COPD. In those cases, we do have to check for that one. Now, there is one more condition that apply here too. When we are doing the low dose CT scan, in that cases, they says up to 3 consecutive screenings. So you have to see if this, like we did screening in 2018, it came out normal. Now we did again in 2019, it came out normal. Then we did 2020. In that case, it came out normal. In that cases, we can stop doing the screening. Screening should only be carried out in the healthcare setting with expertise in the diagnosis and that one. So if there is 3 consecutive times the screening came out normal, in that cases you can stop the screening. Okay. So they're very straightforward lines, but it can be asked in many different ways. Okay, we did 2 tests and 1 test came out abnormal. In that cases, we will continue with the screening. If 1 test came out positive and the second was not good, so in that cases you have to continue. So this 3 consecutive means like each year 3 consecutive, not like with 1 test came out positive, the negative one, second was negative, sorry, second was not normal, and the third test came out normal. In that case, what are you going to do? So 3 consecutive was not normal. So in that case, you have to continue with that. And these questions does, like, when they are written there, you will start getting confused. Oh, what did I read and all that. So you have to think of all the possible consequences which could be written in the scenario. Then we are talking about the colorectal cancer, same, the age factor starting with the 60 up to 74. So then we go, what do test we do go for FOBT or FIT testing, or like if we are going for a stool test like FOBT, fetal occult blood test, in those cases it has to be done every 2 years. But when we are going for flexible sigmoidoscopy, that this is every 10 years. So usually in our setting we go for FOBT or FFIT testing. We don't go for very invasive if there is anything you're concerned about. Like if you're concerned about any mass or any finding inside the colon, so in that case we go for flexible sigmoidoscopy. Now, in which cases we are going to start early. Men and women, if they're symptomatic, diagnostic workup, you have to start it right away. So so you don't worry about that one, Canadian or Alberta guidelines. Usually we have to follow the Canadian guidelines uh, because if there is any difference between the guidelines, they will not test it according to Alberta, according to Manitoba. Although in Manitoba there is different. So where I'm working right now, we do tot kind of different from what is written in the book. But still, when you are written in the exam, they are asking about what's written in the Toronto notes or what's written in the Canadian guidelines. Then won't ask you about the Alberta one or whatever it is. Okay. So men and women asymptomatic regardless of the age. Sorry. So asymptomatic regardless of the age, but positive family history. So in that case, if someone is asymptomatic, but what is the positive family history? If someone has HNPC, PCC, or FAP, in those cases, genetic counseling and specific screening. So HNPC, it's something you have to remember. HNPCC, in this one, you go for colonoscopy. FAP, you go for sigmoidoscopy. AAPC is going for colonoscopy. So how I remember is the one that's end with C. In those cases, we go for colonoscopy. H and PCC, so it's colonoscopy. AAPC is basically colonoscopy. For FAB, we go for sigmoidoscopy. Just for your understanding, it's if that makes it easy. Then, if it's H and hereditary one, then every 1 to 2 year because hereditary can show up anytime. So if that makes sense to you, so like for your understanding, so begin at the age of 20 because after 20 your hereditary characters start showing up, so for your understanding, or 10 year younger than the earliest case in the family if someone is younger. Then comes the FAPS. FAP is basically it's a familial one. So we already know the familial is mainly the congenital ones or the one that shows up early. So in that case, we are going for sigmoidoscopy and it starts at the age of 10 to 12. So for your understanding, then comes the AAPC. It is neither nor the hereditary one, not the fab one. So it comes in the middle, 16 to 18. I hope that makes easy for you to understand. So that's how I kind of try to memorize it. It helps me to, solve the questions a lot. One family member or the first family member, like your first cousin or someone who's close, that one got the cancer, then in those cases, at the age less than 60, two or more the first degree relative in the polyp or the colon cancer. In that cases, you have to do colonoscopy every 5 years, or it could be started earlier if someone showed the cancer in the earlier stage. Then we are talking about one first degree relative with the cancer, which is more than 60. So it was later that age. In that case, you can do the average screening, whatever is like starting from 60. One second family member or the third member, relative effective, in that case, you have to go for because the second family member, that's basically that. Now we are talking about polyps. This is something they do like to ask when they talk about colonoscopy. You did colonoscopy, you find out polyps, now what? So if there is 1 to 2 tubular adenomas, then and it's very small, it's like less than 1 centimeter, then colonoscopy we will follow the same every 5 years. If it's more than two adenomas, like it's more than two, or if its centimeters are bigger, in that cases you have to do little bit earlier, like colonoscopy in every 3 years. Or if there is an incomplete examination, polyps, and you're thinking of cancer and your judgment or clinic judgment, like he's having weight changes, sweats, fever, all of that constitutional symptoms, in those cases you can go for earlier. Okay. So I hope this makes sense. This is very easy table, but do ask a lot of questions from colon cancer. Then comes the cervical cancer, simple, the age. What are you going to do is pap test and what you are looking for HPV. Okay, so for your understanding, we are looking for HPV in this one. And when did it started? Usually it started at the age of 30, but if someone is sexually active prior to 30, so you can start at least 25. So the minimum age is 25, starting from 25 till 69. Okay. So if someone is sexually active in Ontario, that's guideline is different. But for your understanding, if they ask in the exam, it's basically 25. Simple. Then the cervical cancer every 3 years. So that's how we follow along every 3 years. So this says a woman may discontinue the screening at the age of 70 if she has adequate negative cytology screening. And what are those ones? At least three or more negative cytology tests. They did not say it's consecutive. Okay, so don't mix up the words. They says three cytology test is negative, but it does not matter if they're consecutive. Like if someone does like sorry, someone does it 3 years ago and now he's doing it again. So in that cases, you have to see what happened here. Okay, so then some of the most important questions that come from here. Okay, so normal screening is every 3 years. Inadequate sample, repeat cytology in every 3 months. Okay, so because we have to see what's going on. Then inadequate sample, routine screening in the 3 years. Now, here comes the thing or challenging part. Ascus low squamous intraepithelial lesion in those two cases, or AGUS or ASCS, basically atypical low grade ones. Okay, in those cases, we have to see age factor if she is less than 30, or if she is having HPV testing not available, like she's living in a remote areas. Okay, in that cases, we have to check for the cytology in every 6 months. Usually it's applied every 6 months wherever they are talking at remote area. Okay, so I keep on mentioning not available means like someone who's living in the rural areas, they cannot go to a bigger community, or they cannot do, go to for colposcopy right away. You can get an understanding. They will tell you a scenario what they are looking for. So this says a female 30 years old, she came to you, she did a testing, and her pap smear shows atypical squamous epithelial cells. And what are the next steps you are going to do? And then they mentioned that she's living in a remote area. Okay, now they specifically mentioned the remote area is what they are looking for, that either you make a judgment of sending her for colposcopy, or what are you going to do it. So in that case is repeat cytology in 6 months. Okay, even if it says here woman less than 30, so in that case HPV DNA testing negative, so cytology in 12 months. So usually we go for cytology in 6 months. Then if it's negative, then going for cytology again 6 months. So you can see they are talking about two consecutive tests that came out normal. So in 1 year we are going to do two testing. So it can be asked, what are you going to recommend for one of next 1 year? So you have to recommend her two testing in upcoming 1 year. Why? Because every 6 months we are going to do it. So repeat cytology in 6 month, it negative, then again in 6 months, then negative, then routine screening. So in this one, anytime it came out, ascus is positive, then colposcopy. Now again, let's suppose if it came out positive, we did the negative test, we did cytology in 6 months, it came out ascus, and she's still in remote area. Although we tried to send her for colposcopy, but at the same time, meanwhile, we can do cytology in 6 months again. For your understanding, if this says, okay, we did ascus, we did the cytology test in 6 months. It came out ascus, and now she's still in remote area. So what are you going to do is cytology in 6 months, but at the same time sending for colposcopy. Okay, so your choice will still be, if they are mentioning for the remote area not available, your choice will still be cytology in 6 months. Okay, so it's the condition that applied here where they're talking about the remote area test not available. So you have to see what you're choosing. Okay, so in any scenario, if they see or put these conditions, then you have to see if the test is not available for colposcopy, are we going to wait her for whole 3 years or whatever? In that case is no, you have to follow up with her in 6 months. Okay, again HPV DNA testing, we don't do it. Now see, it's written here, but I have never done HPV testing. I go for pap and then I do cytology right away again 6 months. And for colposcopy we refer to gynecologist. Then HPV DNA testing, it's negative, then repeat that cytology in 12 months. So usually it's hardly we go for HPV DNA testing, we usually go for cytology in 6 months again. Now, if there is an ASC colposcopy, but again, if it's a remote area test not available, then cytology in 6 months. Now, again, I guess it's basically the colposcopy plus endometrial epithelial cells to check for the uterus cancer. Again, if the test sample is not available and all that cases, then you have to go for the cytology again 6 months. Then we are talking about the LSIL. In that cases, you have to give the patient choice. This is now a part of choice. Either you tell her to go for colposcopy, either you tell her to repeat the cytology in 6 months. Now this is patient choice. Before we were thinking of what's best for her, although we are going to tell the patient what she wants to do, but here LSIL, she has two choices straightforward. Either go for cytology in 6 months, either go for colposcopy. Then HSIL, in basically in those cases, we go for colposcopy, but again, it's a remote area, test not available, whatever it is, then don't forget to do the cytology in 6 months. Again, squamous cell or malignant one, so colposcopy. Now, this can be asked in which cases you are going to do. I think we already discussed how can HPV be transmitted. So in those cases, we have to do either it's a partner female with female, male with male. In those cases, whatever it is, we have to test for the HPV DNA testing. Okay. Then comes the prostate, which is not screening, not available. But if someone has the prostromegaly, then we go for PSA in the blood. Okay. And it's written here in the book that we don't do recommend screening, but I have been doing it daily basis. For patients who come after 50, we do prostate screening. See, now that does not make sense to me anyway, but still we are doing prostate cancer screening. Then comes the motivation strategies. You need to remember this staging. Just remember the name, what is pre-contamination and what, because the scenario can become, and then they ask you, what is this staging? If they're talking about, oh, patient come to you, in that case is she's willing or she's at the sensitive manner, she's thinking of, or patient is aware of that she's obese or she is doing excessive smoking. Now she come. It means she is aware. Okay. To say they mention a 30-year-old female, she came to the clinic, she is smoking and she is looking for something to help. Okay. So in that case, they did not mention the patient is aware, but she came to the clinic, it means she has awareness. So in that case, this is basically pre-contamination. Now, the contamination in that patient, the patient is ready or patient wants to start, patient thinks that he will be able to do it. Now if they talk about, if they're confidence, if they like he's looking for a medicine, he heard about that medicine and he thinks if he uses it it will go well, then now this is basically contamination. Preparation. Now he took the medicine, he went home and he's ready to start. This is preparation. Action. You gave the medicine, he took the medicine. Now he's going, he took it, like he left, he take it, and you already sport and everything. So this is basically action. Maintenance. Now he came back to discuss how to proceed further with that. Then comes the relapse. He already quitted and now he came back again with whatever it is. Now you can see from the vitamin D, there is only this part that for your understanding how much the regular dose is 1000 international unit, but yeah, we can go up to 2000 to 2500 international units too. For babies, it's 400 international units. Then for the, sorry, this one here for nutrition plan. So you can see this one here, how much fruits should be, protein, carbs, grains, and all that. Okay. Then here. So you need to remember this table, table 3. Carbohydrates, complex carbohydrates should be preferred to the simple one. Okay, then fruits and vegetables, usually fruits and vegetables are recommended. Fats, consume the mono or polyunsaturated fats over the other, minimize the trans one. This can be asked in a scenario, which fats are recommended one. Okay, so I keep on mixing up the polyunsaturated is good or the trans one is good. So trans one is bad, but the polyunsaturated, monounsaturated is good and it should be used in moderation. Then comes the protein. So consume fish with the high omega level, then the lean poultry, the red meat, salt should be less than 2000 and all of that. Now we are talking about the main important that you need to remember, the Mediterranean diet and the DASH diet. So Mediterranean is high fat of the leafy vegetables, fruits, and all of those ones. Low salt intake of the red meat. If choosing to consume the alcohol guidelines, so you have to think of at least 3 drinks. Usually there is no safe level. Then the dash diet is high in vegetables, fruits, or low fat dairy. Then whole wheat, grains, poultry, all of those ones low in the sodium, sweet, low in potassium. So it can be asked what is the difference between the Mediterranean and the dash diet, which one is preferred over which one. So usually the dash diet is preferred for the high blood pressure, and the Mediterranean diet is usually preferred for the people who wants to lose weight. So for your understanding. Then comes the obesity. Obesity, you have to, okay, you can read all of this one, how much it is, whatever it is. Then the main important thing that you remember is this one here, the classification. Usually the underweight, less than 18.5, because they could have that, fractures and all of that one. And then normal should be 18.5 to 24.9. Then overweight is 25. And when does the obesity start? After 30. Okay. So that's basically after 30 is obesity, below 18 is underweight. Now we are talking about the management. So it's basically important in NACOSKI point of view. NACOSKI, this one is most favorite topic of NACOSKI. But again, if something can be asked from here, so association with the low body mass index is basically osteoporosis, eating disorder, undernutrition, and pregnancy complications. So first step is they recognize how do I talk about pre-contamination. Steps two is basically height, weight, BMI, checking every parameters, all of those ones. Then step three is checking what level they are. Are they able to talk about the nutrition, physical activity? Nutrition is like we talk about nutrition. Then physical activity, doing 30 to 60 minutes exercises, all of that. Then there is something here. Is it the aerobic exercise or is it the anaerobic exercises? Which one is recommended for which kind of individuals? So resistant training may promote the weight maintenance and increase muscle mass and the fat one. Then the regular activity can cause the cardiometabolic risk factor. So you need to see which one we are talking about, the resisting one or the regular training. Then the psychological and behavioral, obviously the motivation, CBT, behavior, all of that things works together. What are the obesity pharmacotherapies? It's written here, the medicines. What are those ones? The naltrexone and bupropion, liraglutide, or listats. That's what you need to remember. So naltrexone and bupropion usually works control hunger and cravings. So if they ask about if someone is looking for a craving in those one, it's the naltrexone. How I remember is basically the opioids one works for the cravings, as opioid has the craving. So naltrexone, we remember this one, and bupropion works with the craving. Liraglutide, what causes it decreases the appetite. Then the early stat, it causes the fat absorption. So you need to remember the mechanism of action because they can tell you that a female is looking for you. She said, "Oh, I consume this much milk or this much dairy product," and she's mainly talking about fat. Now she wants something which helps with the fat absorption. So they are looking for early stat. Okay, so it's very important. Then all of the medications when you're giving, you have to see. Then bariatric surgery. So if you cannot read the whole thing, and I mean, if it's your first time, then you can read the whole thing. But if you are doing a quick revision for you, you can just do this one. So overweight, obese adults, measure BMI, waist circumference. BMI is more than 25. In that case, circumference is above cutoff point. Then the clinical and laboratory investigation checking for BMI, blood pressure, heart rate, glucose. So as you can see, if an obese 28 years 25 years that comes, in that cases we do the lipid profile. But if a normal single individual, like without any comorbidity, without any obesity comes to you, we don't do the lipid profile until 35 or at least 30 years of the age. Okay, so you have to keep it in mind that what we are talking about, in which kind of class we are talking about. The ratio of the total cholesterol, then assess and screen for depression, eating and mood disorder, treat comorbidities and the health guidelines, then change behavior and barriers to the weight loss. Then the device goals and the lifestyle modification for the weight loss and the risk factors checking for the loss goal, how much they are looking for. Then health team to advise the lifestyle modification where you're talking about nutrition, physical activity, CBT, what is your satisfactory progress or the goal achievement, regular monitoring, assist in the weight management and the health benefit. Then we are talking about the weight maintenance, weight reduction, nutrition, and all of that works together. Then pharmacotherapy, in which weight or BMI, we are going to start the pharmacotherapy. So BMI more than 25, 70, sorry, 27, or BMI more than 30. More than 27 when there is risk factors like heart condition, high cholesterol. In those cases, we have to start the pharmacotherapy. And then adjuvant lifestyle modification obviously works along with that. Then bariatric surgery, in which cases where there is a BMI more than 35 or BMI more than 40. 35 when risk factors like heart condition, cholesterol, thyroid, everything is there. Then the dyslipidemia. When someone is asking me how to memorize this one, I feel like what you need to memorize is FRS score, okay? And at least one of this one, either LDL, either HDL, either EPO, whatever you could remember. More than enough for you. So when we are talking about the low risk, it's basically FRS is less than 10%. Intermediate risk, FRS is 10 to 19%. And if that's given, then LDL is 3.5, then HDL is 4.3, and then APO is 2.1. So in that cases, then age to 250 to 360, those ones is this is basically primary prevention. Then statin induced prevention is basically where the atherosclerosis, aortic aneurysm, most diabetic, and then LDL is basically genetic dyslipidemia. Now, if you ask me what kind of question that can be asked from here, so usually they give you a female, she's obese, or she is having this. In that cases, what are you going to do? So in that cases, we do order this lipoproteinemia or the lipid profile to check for what's the risk for that one. And how often do you do it? Now, see, it's written here repeat screening every 5 years. But if you ask me, we do repeat screening every 1 year. It's kind of different what we practice or what's written in the books. So, like, for your understanding, if they ask you in that cases, you have to see that we are going to do it every 5 years. Okay. The FRS scores is given every 5 years. And believe me, you don't need to remember how to calculate FRS, how much apolipoprotein, because now we are practicing it. So there is already, the computer system that we are using, there is already our count calculator that we check the cholesterol, we put the cholesterol there, we put their diabetic, smoking, and they calculate a Franklin risk score for us. They tell you it is high, it is intermediate, it's low. If it's high, we start the rosuvastatin or any kind of statin. If it's intermediate, we do offer them and we do start our main choice is we do start it. In low cases, we tell them about the lifestyle modification. It's simple, it's very straightforward, and it's very easy to calculate it. So you don't have to remember any formula. You don't have to go into very detail of this one. They are not particularly looking for you to calculate it or tell you the values of this. All you need to remember is in which cases you are going to start the statins and what are the potential side effects of statins. So please try to understand. I understand there is so many people in the groups try to tell you, okay, try to remember this, try to remember too much. It's not needed. What's important is because when you are doing everything, then you forget what's important. So this is not important calculation, the values, some of the values they are given because if they are giving LDL value, if I can recall correctly, they can give you the normal values along with that one. If they're particularly looking for you to do something. I mean, it's hardly that it could be like, something that could be challenging. Then the high risk is FRS is basically 220. And then in those cases, we have to do the repeat screening every 5 years. Then the discuss behavior modification in which one is that one smoking cessation, diet and exercise. In that one, you have to initiate the statins. Uh, so you need to know which cases you start the statins. So you can see the statin indicated conditions are already written here. In the primary prevention conditions, there are already written that, if someone is having a low risk or even the high risk, that in those cases, you can discuss the behavior modification. You can still wait for it. You can still wait and see if they don't have any much heart condition. In those cases, even somebody who has high blood pressure, they don't have a smoker, they're not smoker, they're not diabetic, we don't start statins. So please keep it in your head that hypertension itself is not enough to let you to start the statin until unless start someone has the diabetes, now high blood pressure, now kidney disease, So stuff like that is built up together. Now they are having high cholesterol. So you can think of that one. Then that totally makes sense to you. Then you can start the statin as well in this patient. Okay. So initiate the statin target, and then our target is keeping it less than 10, the LDL, or at least more than 50% of the reduction, or whatever we have started. LDL is more than 50% reduction, so then we can maximally tolerated dose. If not, then add on therapy, and we can see which one we can add, ezetimibe or ezetimibe with PCSK9 inhibitors. So we can add then. If then is that one, we can monitor the response to the statin or health behavior, how it's working for you, how good it is. If not, then